Great. So thank you for the opportunity to speak. And I think today I'm going to go a little bit of a biopsy of how we've used electronic health records in eMERGE and locally, and some of the experiences from these networks to inform how we might use them in the future. And so a little bit looking at our own biobank as one example of what we have. We have 196,000 people in our biobank. The mean follow-up is about 6 years. You can see the number of codes, labs, drugs there. Some things to highlight there is we have 26 million notes on these people, so an average of 132 notes per individual, which includes not just the clinic notes, but the phone call records, the patient health messages through the patient portal. We have 2 million radiology tests, so about 10 radiology tests per person. And so they are dense, and I think we all recognize that they're probably becoming increasingly dense over time. Now, our approach to phenotyping is much like Mike Gaziano presented yesterday. We start with identifying a phenotype of interest, and we propose a case and control algorithm. Both of those elements require an algorithm to really know who does and who doesn't have a disease. Someone who's never had a glucose value is not necessarily a control for diabetes, for instance. Then we do a manual assessment and assess the positive predictive value or precision. And we found that that first proposal is almost never right. We almost always have to do another iteration. So if the positive predictive value is not sufficiently good, we go back and revise and pull a new set of cases and controls and evaluate, usually with physician review. And then we deploy at a given site. And then we validate at other sites, and typically there's a little bit of tweaking that happens in that second site and maybe the third site. But then after that, you have a transportable algorithm that can be deployed across 10 sites with good positive predictive value. You can pull in your existing genetic data and then perform your association tests. And so what we found in doing many of these algorithms, there are over 80 that we have in PheKB right now, which I'll mention later, a site that has collected these, is the billing codes are necessary but not sufficient. Most algorithms do have billing codes, and they're an important part. And then we layer on top of that natural language processing of clinical notes, medication records, which are markers of severity of disease, as well as presence of the disease. And importantly, we have a lot of electronic prescribing tools today, but when you look historically, a lot of these data come from telephone records and are just mentioned in notes and then handwritten. So we employ natural language processing to get a full record of prescriptions. And then laboratory and test results become an important element as well. And some intersection, usually in Boolean logic or scoring metrics or machine learning algorithms, that derives our set of true cases. And sometimes we can actually assign a probability of how certain we are someone is a case. And so when we look at a given disease, and this is just one example of rheumatoid arthritis, you can divide any given population up into 4 buckets. You have a set that are definite cases that we really know based on the algorithm that they have the disease, and you have a set of controls that you know really don't have the disease. There are a lot of people in the middle that maybe don't have a deep enough physical exam or don't have the necessary laboratory testing that you just exclude from your analysis. And then there are patients, if you have a rare phenotype, that are possible cases, that if you want to use them, you can manually review them. You can move kind of the slider bars based on your size of your disease population and your tolerance to imperfection on these. But it's a basic breakdown that looks something like this for many diseases. I wanted to give a few examples of cases in which this has worked. So in this case, we have 5 diseases and 21 single nucleotide polymorphisms that we tested for these 5 diseases. The red boxes represent the published odds ratios at the time. The blue diamonds represent what we found in our study using about 10,000 patients. And we are underpowered for most of these analyses, but we replicate 8 to 9 of the associations. And importantly, really all the associations are on the correct side of the odds ratio line. So we took this to mean in this early study that we could replicate findings, and there are many more of these kinds of studies that have come out. I'm going to give you an example from eMERGE. So at this point in eMERGE, it's 2010, we've done each of the 5 sites in eMERGE 1 have genotyped about 3,000 to 4,000 patients for a given disease of interest. And then we asked the question, can we take these extant samples and use them to look for an entirely new phenotype? And the phenotype we chose was autoimmune hypothyroidism. And this shows the number of patients that were genotyped for the given 5 diseases the sites investigated. We developed an algorithm at Vanderbilt and validated it and then deployed it across the network. You can see the positive predictive values were good across the network, and then we took those samples and then did in silico GWAS based on the existing data, and we found a new signal associated with hypothyroidism. And that became the model for eMERGE 2. So all the investigations that happened in the second round of eMERGE, that's nearing completion now, used existing data. And so these are a list of the completed GWAS so far. The ones that are in bold have had significant findings. About 2/3 of the ones we've investigated have been significant. And importantly, we're also, if you look at the far right, able to contribute to a number of networks. So we can mix things with Charge and Giant and other consortia to find significant results, and usually find similar results using EMR data as we do from clinical trial or observational cohort data. I mentioned earlier that these phenotypes are collected on a website so they can be shared to other networks. This PheKB website is used by eMERGE, PGRN, PCoreNet now, and other networks we're in discussion with to put these phenotypes up there, let them evolve, capture that data so that other people can download and use validated phenotype algorithms. And you can see we have about 85 of those now and 118 implementations of those 85 algorithms. I wanted to give you an example of one phenotype algorithm. This is the hypothyroidism algorithm. And you can see that it uses codes and it uses labs, medications, and it does things like how many instances of these have been recorded. Timing was important, so we didn't want to have hypothyroidism just in the presence of radiation exposure, for instance, or pregnancy. So this algorithm gets validated and used multiple places. Overall, if you look at all the implementation data we have on PheKB, the red diamonds here represent the performance of those algorithms. You can see that the positive predictive values are greater than 90%, both at the site that developed the algorithm and at the secondary sites. There are some outliers, and these tend to be rare diseases that you don't want to lose any cases. So drug-induced liver injury, a given site may have 3 or 10 cases. They're easy to review. You don't want to lose any possible cases. We talked a lot about genome-wide association studies and sequencing studies. One potential you have with electronic medical records, as well as other richly phenotyped cohorts, is the possibility of doing the inverse experiment, or phenome-wide association studies, where you look at a given genetic loci and look at all the phenotypes that could be associated with. And one requirement of that is to have richly phenotyped sets. That's available in EHRs. It's also available in other large observational cohorts that robustly assess phenotypes. I just gave you one example from a PheWAS done on IRF4, which is known associated with pigmentation phenotypes, and you can see a number of pigmentation-related skin diseases come up as associated with that variant. You can also use EMRs to look at drug response phenotypes. So this looks at 31 drug response phenotypes we looked at. At the time, there were about 120,000 people in BioView, and an important finding is that ends up being a small sample size when you want to look at a rare adverse event like heparin-induced thrombocytopenia, which we found about 70 cases for. Another important aspect of this is 90% of these patients that we genotype participated in more than one study. So the data gets used and reused. And in fact, if you looked at the samples used across all of BioView, only 30% of them that have been used once. 70% of them have been used more than once. So some of the strengths: rich longitudinal data stores. We have the ability to go back to the chart to find out more. So you have a rare variant, you can go read the records and see what happens. I believe that we can find research quality phenotypes using algorithms. You have the potential for closed-loop discovery and implementation, like Rex said, that we can actually discover something, put it back in a learning healthcare system, and modify the system. We have a lot of expensive testing that's been done and paid for others, so available for free for these exercises. We have the ability to explore rare, detailed drug response and mortal phenotypes if they're collected prospectively. Samples can easily be reused as well. Some challenges are developing these algorithms does take time and people, and implementation often does require local expertise. The EHR data can be inaccurate, heterogeneous, unavailable. They can lack organization. That organization differs between different EHR vendors, and the storage and policies at how you get at the data can vary between EHR vendors as well. There's fragmentation of patient populations when they visit different healthcare systems. And mining the EHR data is not trivial. It requires things like natural language processing. Duration and temporality can be challenging things as well. So I wanted to mention a little bit about sharing genetic data that we found through eMERGE. So if you were to take 5 sites, like we had initially in eMERGE, and just look at the net connections between them, and if we all made agreements with each other, we would have formed 10 agreements to share the data, which is doable. But if you make an agreement with one central coordinating center, you only have to make 5 agreements, and then that data can easily be shared across the network. And this is something well known to anyone that's computer science, just sort of the n squared growth of the number of agreements you have to make. So if you have 10 sites or 20 sites or 30 sites, it clearly becomes impractical to share this data. And this was actually it seems like an obvious point, but a very fundamental point to making eMERGE work quickly for doing new phenotypes. You've heard a lot about eMERGE. We're not the only network with a lot of EHR samples. Kaiser has a number, and so does Million Veterans Programs, as you heard. If you look across all these, we have more than 1 million people now that have DNA samples, and that number will obviously grow significantly. And about over 350,000 of those would have available genetic data to date, just in the US. So I think it forms a good foundation for starting among the existing cohorts.